word. Haha. So Dawn, please take it away.
Good morning, everyone. It's actually super gratifying after basically a year of thinking about CROI, and as the community liaison subcommittee does, and then the months that Jim leading the charge with the AVAC team and others to pull these margarita breakfast clubs together, that you get up bright and early and there are 100 of you who are deciding to do that. So I just want to give a shout out to everyone who gets up a little extra early to participate, or late if that's what it is at home, if you're eating your dinner while we're doing this. I am delighted that we're going to talk this morning and hear from some awesome speakers to talk a little bit about what's going on with the missing data and the gaps in women and children. And I'm not going to talk a lot because I hope that what we'll do is get a little bit from each of the speakers and then really have a robust conversation. So after the last couple of days, if there have been bits of data that you've heard or things you haven't heard, I hope that we can kind of raise that in this conversation and have a nice dialogue before we get into the main session this morning. So without further ado, I actually don't have the good pleasure of knowing our speakers personally. So I think what I'm going to do is just start with Lee and ask Lee to come on camera and start the conversation. And please, as always, feel free to put your questions in the chat, and we'll be monitoring that so that we can have a great conversation. So thanks, Lee.
Thanks so much, everyone. And I'm on the other end of the world. I'm dialing in from Johannesburg. I unfortunately wasn't able to join CROI this year, but it sounds like I'm certainly missing out. So good morning to everybody, and I apologize. It's my dogs, I think, are barking in the background. But I think what I really wanted to do for the session was just to highlight some of the Be Protected and Deliver results that some of you may have already caught at CROI, but perhaps to really discuss a little bit about what the need is in pregnant and breastfeeding women in terms of their need for prevention of HIV, and then really just discuss a little bit about each of the studies and actually where we are with the Deliver study, which is still ongoing. So, I mean, I'm certain that this audience doesn't really need much of this background, but really, just to sort of remind people that obviously, women need to have HIV prevention methods that they can use at all times of their lives. And obviously, some of these methods might suit them better at some time points. Some may suit them better at others. And obviously, people are always very concerned about pregnancy and breastfeeding, and whether, whatever product that they may choose to use is actually safe during those periods. And so that's really, why the Be Protected and Deliver studies were developed amongst, within the MTN network. We know that the risks of a woman actually acquiring HIV infection during breastfeeding is up to 4 times higher, and in pregnancy 2 to 3 times higher than at other times in their lives. And obviously this has a number of repercussions, including potentially that their infants might be infected. We know that women, particularly in sub-Saharan Africa, actually spend a large proportion of their lives pregnant or breastfeeding, and we really need to make sure that we accommodate their desire for HIV prevention during those time periods. And often we know that, I think certainly the landscape is changing, but we know that we come from a background of, women who are either intending to become pregnant or pregnant and breastfeeding, often actually excluded from clinical trials. And so, I think increasingly people are thinking about how women can be brought into clinical trials earlier so that we have this information ready for pregnant and breastfeeding women, and that they're not kind of right at the end of the queue when they're new products. But it certainly has been slow. And I think one of the things we're very proud about with these MTN studies is that they have in some ways really sort of been trailblazers in terms of including pregnant and breastfeeding women. So we know that there's a fair amount of information known about oral PrEP as Truvada. A lot of that information comes from the HIV treatment trials, increasing amounts coming from HIV prevention trials. But certainly the Depivirine ring, which is really one of the only products that have been specifically designed for women, there's far less data. And so we know that there was some data from phase 3 trials, Aspire and the Ring study, which were looking at women who were not pregnant, but then basically when they became pregnant, stopped the product. But there's some information from early on in those pregnancies, and there was no difference in pregnancy or infant outcomes in those studies. And then in terms of breastfeeding, also there was a US-based study done a number of years ago now, but really was aimed at looking in women who actually weren't breastfeeding but were able to produce breast milk, how much transfer of Depivirine occurred, into the breast milk and then into the woman's blood. And what those results showed, that there was really very, very little transfer. So certainly reassuring. And so with these studies, we've really been aiming to try and get this product into pregnant and breastfeeding women as soon as possible, with as rigorous a study design as possible. So the two studies that have been conducted, so I'll talk about them maybe a little bit back to front, because usually we talk about pregnancy before we talk about breastfeeding, but the Be Protected study has actually concluded, and those results have been presented at CROI. And then we'll discuss the Deliver results, which there have been some results presented at CROI, but the remainder will be presented once the study concludes. So essentially, Be Protected was the first study that was conducted in women who were actively breastfeeding. The study randomized women 3-to-1 to Depivirine ring and oral PrEP. So obviously we wanted more safety information about the Depivirine ring, and that's why many more women used the ring during the breastfeeding period. We also obviously included Truvada. We know that Truvada is a highly effective prevention mechanism, and we knew that this would contribute more safety data, I guess already to a field that has a lot of safety data, but obviously, there's no way one can actually randomize to placebo when we know that there is effective treatment out there. So basically, the researchers really did not find any concerns in the study. So when looking at Depivirine levels in women and then in their infants who were breastfeeding, in fact, in infants, there were negligible or virtually no Depivirine was detected. But in women, as expected, and in their breast milk, there was Depivirine detected, but in very, very small amounts. And those levels dropped off very quickly once the product was actually discontinued. So really, we believe that this study demonstrated that the Depivirine ring is safe and works well in breastfeeding women. We know that the product is registered in a number of countries. So far, the registrations have not included pregnant and breastfeeding women. So we're hoping that this will obviously be the next step. Then just to discuss the DELIVER study. So the DELIVER study is a study. The DELIVER study basically was conducted in pregnant women. The study design was sort of gestational age de-escalating, or a sort of decrease in gestational age, enrolling 3 different groups of women. So the first group of women were enrolled from 36 weeks upwards, so really the very end part of pregnancy. The second group were enrolled between 30 and 35 weeks, and again in the 3rd trimester, quite late in pregnancy. And the final group is currently has been enrolled and is currently being followed up. And that is actually looking at the earliest stages of pregnancy, so from 12 weeks to 29 weeks. And the reason that we did it in this way is that we know that most of the sort of risks that might result in sort of any what we call congenital anomalies or abnormalities in the baby occur if a woman is exposed to a product, for example, very early on in the pregnancy. So, and we wanted to start at the sort of time period that's the lowest risk. So, you know, once women had been beyond a time that they would be at risk for any preterm delivery or anything like that. So that was the study design. Again, women were randomized. It was slightly different in each of the different groups, but randomized to the Depivarine ring and oral PrEP. And we had presented the group 1 results previously, but in CROI this year, we've actually presented both. So we had about 150 women in group 1 and 157 women in group 2. And basically what we have found with these studies is that there's no increased risk during the 3rd trimester in pregnancy for women receiving the Depivarine ring and in fact oral PrEP. So the one thing that we did do before we actually started with this clinical trial was we did a study called 042B, which really looked at pregnancy outcomes in the sites that the study was conducted. And so we had a good sense of what we could expect from the sort of general population in terms of what we would think might happen with pregnancy outcomes. And just to add that the studies were, that in both of these studies, they were conducted in South Africa, in Zimbabwe, in Malawi, and in Uganda. So in the DELIVER study, we've been able to move on, as I've mentioned, to the 3rd group. We're currently busy with follow-up, and we still have a fairly significant proportion of women who still need to deliver. We follow the woman up to 6 weeks after delivery, and then the infants up to 12 months. Just to mention that, you know, obviously doing studies in pregnant women actually does tend to be fairly complicated. Unfortunately, pregnancy is not a risk-free zone. So, you know, we do need to take into account that any side effects that can obviously happen, or any kind of complications that can happen in the general population, can certainly happen in studies. And I think one of the very reassuring things is that any of those sort of adverse events have been much lower than what we've seen from our data from 042B in the general population. So I will stop there. Thank you.
Thank you, Lee. First of all, you deserve a special psychological award for navigating all of the extra. This is like
surprising.
Yeah. I mean, I can't speak, and therefore I can't even imagine what it's like to try to be talking when you're looking at tiny little boxes and getting crazy background. So thank you for that, and thank you again, because, you know, as a women's activist and advocate for decades now, this, as you well know, has been the longest slowest haul. We have been fighting for this for so long. So it's really incredibly important right now for us to see all of the extraordinary work around prevention and the realization that this is real life for women living with HIV and at risk for HIV. So thank you. I won't belabor that anymore because we have both Jane and Imelda to speak as well, and then get a little conversation going. So without further ado, and without any formal fancy introduction, I'm going to turn now and ask Jane to share a little bit about her work, and then of course ask Imelda to kind of bring it all together for us. So Jane, over to you now. If you're, let me see, are you there? Pop up in my screen.
I'm there. Good morning, and thank you for the opportunity. Yeah, my name is Jane, like I've been introduced, and I come from Kampala, Uganda, and I will be sharing with you a few insights around, the gaps in data around women and children, but also share with you some of the results that we got from our study in Uganda. Again, apologies that we have not used slides today. I think it's better to have it interactive for the discussion. But as I thought about this, one of the things that came to my mind were really some of the glaring gaps that have been around women and children and research. And for long, participation and involvement has been restricted, of course, bearing in mind what Lee has just shared about the risks that concern participation of pregnant women in research. However, I think that in addition to the restrictions and the anticipated risk, there has also been a lot of restriction around decision-making and involvement of the woman who is responsible for the pregnancy and the child they are carrying in decision-making concerning what happens to their lives, but also what happens to the lives of the children that they're yet to deliver. And so I thought that, together we all need to appreciate that as we move forward in this journey of making the lives of women better, improving maternal health, but also ensuring that vertical transmission becomes history. I thought that it was important for us to appreciate that we must take deliberate efforts in all that we do and ensure that we are including and involving women in decision-making as much as we can. And once we do that, then there will be a narrow gap in terms of the inequalities that have for long been affecting us. So in our study, which I have been leading and conducting in Uganda, and I also didn't mention that I'm a doctoral student, and so this is part of my work that I've been doing. We thought about the gaps that are around women and vertical transmission. And we also note that in terms of winning the battle to vertical transmission, we must be able to achieve viral suppression. And so in this study, we sought to optimize viral suppression and ensure that women that were enrolled in the enhanced SPS trial achieved viral suppression. And so one of the key concepts that we used in this study was to ensure that the woman became a key stakeholder in as far as deciding and thinking about what happens to them while pregnant is concerned. But also it is the desire of every woman, to really have a satisfying pregnancy period, but also give birth to a child who is free from any abnormalities or free from any diseases, especially if they are preventable. And so we designed this study, and I'll keep it simple just to make sure that we appreciate the role of women involvement. And in this study, we wanted to ensure that the woman understands what it means to have a suppressed viral load while they're pregnant and while they're breastfeeding, and also make sure that they appreciate that the current evidence actually supports viral non-suppression as the key predictor to vertical transmission. I will just share a slide that that shows you know, some of the key points that we are focused on. I hope you can see my slide. And so in this slide, we made sure that we introduced the concept of the viral load, which for long has been known to be the predictor, and ensure that every woman understood what it is and what it meant to them if they're pregnant. And so we also used simple terms to make sure that they're able to appreciate and that it is a joint responsibility between us, the providers, but also them as the women that are carrying the children, and ensure that they understand what their responsibility is in terms of becoming suppressed and having a healthy child. And so these are the simple, you know, talking points that our peer mothers used to provide what we call viral load counseling. And we also made sure that we provided the viral load results, and every woman was able to know that, you know, this is my viral load, either suppressed or not suppressed, and what does this exactly mean in terms of my journey of pregnancy and childbirth. And so after having that started, we followed these women up for a period of 1 year, and were able to register an improvement in viral suppression of around 25%. And this was most especially among the young women aged 15 to 24 years, where we saw a 42% increase. And again, we know that this has been one of the age groups that for long has been lagging behind, and we're excited to see them come on board and also have them suppressed as they are pregnant and as they go through the journey of childbirth. We also looked at the women who are HIV positive, and previously, you know, there was an assumption that if you're HIV positive, you know, you shouldn't be thinking about childbirth for so much, but rather think about your health, especially in the resource limited settings where I come from. But one of the other key goals of this study was to ensure that if a woman becomes pregnant while they're HIV, we are able to ensure that they know their starting point in terms of viral suppression, and ensure that, you know, if they're suppressed, we maintain that suppression throughout the pregnancy. But also if they are not suppressed and they have found themselves pregnant, we ensure that we support them with the information they need and the support they need, and ensure that they become suppressed. And in this study, we were able to have about 98% of our women maintain suppression, and about 88% achieved suppression. And so overall, we observed that once you involve the woman and she takes responsibility about their health, the chances of achieving viral suppression are very high, and we believe that this is going to also be reflected in the next level of analysis, which will be looking at infant transmission in this cohort of women. And finally, as I come to the end of my talk, I just wanted to say that, you know, it is the right of every woman to have a very satisfying experience while they are pregnant and while they expect their child, and even while they give birth. For the women I have engaged and personally having gone through that experience, I believe that is all our role to ensure that it becomes very satisfying to everyone. But also, in addition to focusing on just the pregnancy and the baby they are carrying, it's important to appreciate that women take a vital role in family care and taking care of the other children. And so using that again to help them appreciate their role in the future and their role in taking care of their families was very important in this study. So it is very important that we advocate for, you know, ensuring that women are able to tell at what point they are in terms of viral suppression, and that can only be achieved if they actually are able to know their viral load at that particular point in time. We have gaps in the different systems when it comes to viral load testing and monitoring, and specifically if I can speak from the perspective of Uganda. And we know that in the general system, it takes probably 1 to 3 months for a viral load result to return to an individual woman. And during that period, a lot can go wrong, and we can lose either the mother, or even we can have the transmission occur during this season. And so we would like to, moving forward, advocate for point of care viral testing for pregnant and breastfeeding women, so that at any one time they're able to appreciate how their viral load is and how important it is to them as they go through the pregnancy and breastfeeding period. I would like to pause at that, and I'll enjoy the questions that will come after. Thank you.
Wonderful. Thank you, Jane. I already have several questions bubbling up, and I know that there's going to be others in the chat. I apologize. I'm having a few technological difficulties here, so I'm sorry not to be on screen here. In any case, I'm going to hold my questions until after Imelda speaks. I hope that those of you who are listening can feel free to put some questions in the chat. You can we'll also all kind of come back into a gallery and have a conversation. You can raise hands and we can discuss, but there's a lot of really important information here. So without further ado, I'm going to ask Imelda to come on screen and to share her perspective for a few minutes, and then we'll start a conversation. Imelda?
Thank you. I'm really excited to be a part of this conversation, something that is really close to my heart. I will try to provide some general impressions, obviously, as a non-scientist, and I also don't have slides, so you'll have to endure seeing my picture and hearing my voice. Unfortunately, where I am, they've been doing some maintenance and our connectivity is pretty low. I'm actually in the lobby where there seems to be better connection. But the studies presented today for me providing a glimmer of hope as we move towards getting much needed safety data for the ring in pregnant and breastfeeding women or populations. And it's just great to see researchers who respect women's rights and decision making. And why is this important? As already been mentioned by both speakers, with more than 19 million women living with HIV worldwide, and the majority of those being of childbearing potential, it's alarming that pregnant and breastfeeding women and children are usually excluded from clinical trials of new agents. And if they are included, women are typically underrepresented in pre-licensure drug trials, and they're usually required to use dual contraception to participate. And then also those who become pregnant while participating in a study are asked to discontinue the study drug. So what this essentially means is that pregnancy safety and PK data on safety in pregnancy for new drugs are routinely delayed as much as a decade after initial drug approval. The studies are performed at all. And so it results in substantial delays in women accessing new and better drugs. Now, although there are clearly ethical considerations when including pregnant and breastfeeding women in clinical trials, it can also be considered unethical not to test new drugs in pregnant women in a controlled setting. In practice, once these new drugs are approved in adults, their use rapidly expands to include pregnant and breastfeeding women, exposing more mothers and infants to these potential risks that would have occurred in the context of a clinical trial. This means that women have to make decisions about using new drugs without adequate information about dosing or safety in pregnancy. So equity demands that research is more inclusive of women. Now, when you look at these two studies, what does this mean on the ground, and how may they impact policy and programming? So hearing about these two studies is exciting, as they're obviously intentional about including pregnant and breastfeeding women and getting safety data to inform not just policy, but programming. What this means is that with the data like this, especially on safety, WHO can review and add to the list of similar research that will inform guidance. This data will support updates to WHO and national guidelines to include breastfeeding people when recommending oral PrEP and the dapivirine vaginal ring as additional HIV prevention choices. It also means pregnant women are not left behind as new products come to market. Even though oral PrEP was approved several years ago, there are some countries that still exclude pregnant and breastfeeding women from accessing it due to lack of adequate safety data. I believe South Africa may still exclude pregnant and breastfeeding women from accessing oral PrEP. I apologize if this has since changed, and I'm not aware of it. Another real example of the impact of data gaps in pregnant and breastfeeding women or populations. A few years back, I think around 2017, we had the big scare around neural tube defects associated with the use of GTG in pregnant women from the Tsepamo study. And countries quickly moved to exclude women of childbearing potential from GTG. For those countries that included GTG for women, it came with strict contraceptive requirements. Again, denying women a drug that was more robust than current formulations. Fortunately, we saw women across the globe take charge and push back on this, forcing WHO in countries to take on a more reasonable and informed approach. Women demonstrated that they are well capable of making tough decisions, including about their fertility and their ability to make choices and changes when necessary. That is the level of advocacy we need to ensure we keep women at the center of research and allow them to participate in decision-making. I love that both these studies design their research with women at the center. So what more needs to be done? There's a lot. While there has been a push from various groups or initiatives like AVAC, phases, WHO impact, PREGLAC, among others, to include women and especially pregnant and breastfeeding women earlier in trials, we need communities to further amplify their voices to this cause. That means when protocols come up, we need to question researchers about inclusion of pregnant and breastfeeding women. We need to push for more relaxed requirements on contraception. For those of us that are in cabs for trials, let's ask the right questions about responsible inclusion of cisgender women, including pregnant and breastfeeding populations. We need to challenge our regulators, who often are protective and conservative about inclusion of pregnant and breastfeeding women. I love how the phases study identified 3 major conceptual shifts that will facilitate inclusion of pregnant women in research. They are saying we should consider pregnant women as a complex population rather than a vulnerable population, moving from protecting women from research to protecting women through research and promoting fair inclusion in rather than presumptive exclusion from clinical trials. For this to work, obviously it requires a multi-stakeholder approach. So I guess for me, the question is, how do we do better? How do we close that gap and ensure that women are included? Pregnant, postpartum, breastfeeding, and otherwise. In the AVAC phases think tank action plan and also the call to action that WHO Impact developed, there are similar actions calling for civil society and communities to be engaged as partners in each stage of the HIV treatment and prevention research, including surveillance process, including identifying of the research questions, protocol development, study implementation, even results interpretation and dissemination. Above that, communities and civil society also, we need to take the lead in building community literacy, peer education, and advocacy on the inclusion of pregnant women in trials and active surveillance programs for these HIV agents. We should continue to partner with researchers to develop tools to aid in communication about the need for clinical trials and surveillance in pregnancy, as well as the interpretation and application of their findings when they are available. There's also been a recommendation for regulatory authorities and ethics committees to incentivize and support inclusion of pregnant women in clinical trials for compounds with potential for use in pregnancy. What that looks like, I'm not sure, but if this is done in an ethical manner, we could start closing the data gap. I'm going to stop here to allow for discussion. Thank you.
Thank you, Imelda. You said so many things that I think many of us were nodding our heads in agreement or pounding our fists. And, you know, I think your comment about protecting women through research is exactly right. And an argument that many of us have been making for a very long time. I know that each of you have experiences in Africa, and I think that many of you are aware that the US guidelines just changed to allow pregnant and breast and chest feeding women, some really important new guidelines finally happening here. And I think that's a great example of where we, frankly, in the US are learning some of what you all have known for a long time. I think sometimes we make an assumption that it only goes the other direction, but I think that here your leadership has been something that has certainly helped people and helped women in the US make some of these arguments. So I wanted to start with a little bit of a moderator's prerogative and follow up both with Jane and Lee. We talked about the goal of viral suppression during pregnancy. What kind of experience do you have keeping women on therapy, allowing them to still have access to therapy and staying on antiretroviral therapy after they deliver, so that you're sustaining their ARV use and access to ARVs?
Jane, do you want to go first, or do you mind?
You could go first.
Okay.
Sure.
So, I mean, we haven't presented any data here at CROI, but certainly what we do know about the postpartum period is that it certainly is a challenging period for anyone. You know, there's a lot sort of going on, and I think that trying to, you know, take ARVs well it's really challenging. I think that certainly my sense is that, you know, some of the treatments that are kind of newer, I guess, but probably, you know, a drug like dolutegravir has been around for a while now, but only really recently. I mean, in South Africa, there was a little bit of a delay even in switching women to dolutegravir because of COVID, I think, and, you know, reduced access to care, which really, I think, set the program back quite a bit. I think coverage is much better now, and we certainly expect better viral load suppression rates, but it really is a very challenging period. I think that some of the newer modalities are exceptionally exciting to think about in postpartum women. So, you know, long-acting CAB and rilpivirine, because it possibly ties women over at, you know, at a time that they just, the last thing you want to think about is having to take your treatments every day. You've got a child that you're breastfeeding, etc. So, you know, I think we don't have a good handle on, I'm sure actually there probably has been data shared at CROI about, you know, how well viral suppression rates are with the dolutegravir era, but I think, you know, we know that with efavirenz, for example, they weren't great in postpartum women. And so, you know, we can all do better. We can do better with treatment. We can do better with support. We can, you know, there are a number of ways that we really need to try and optimize treatment, mainly for the mother's health, but also to try and prevent transmission. Thanks.
Yeah, great, thank you. I'll just add something small that definitely, as Lee mentioned, the postpartum period is challenging. You have a new baby, you have to learn to breastfeed. Sometimes they're first-time mothers, and all this is a new experience, and it's never easy. And what we have found helpful is really the continuous support, especially in our study, we used the peer-led model. And the peers have gone through this experience, and so they you know, they talk to the mothers from a perspective of, I have gone through this, and this is how you can go through it successfully. And so that shared experience and continued support is very important. But we have also noted that depending on the settings and the context, most women tend to actually move away from their primary residence and either go to their parents or friends for support in the initial postpartum period. And that becomes a period when most of them may not have access to treatment, may drop out of care. And so again, one of the strategies that helped us in this was making sure that the continuous phone calls, I did mention that we provided bi-weekly phone calls to check in on these women. That was helpful. And for those that were constrained severely and were unable to come back to the facilities, where need be, the peer mothers supported them with a drug delivery. Thank you.
One quick follow-up. I love that you have peer mothers. How many peer mothers do you have, and do they get compensated for that activity, or is it a volunteer role?
So for each of the facilities that we enrolled in the study, there was one peer mother who was already part of the system. We found them existing, and all we did was to train them on the importance of viral load counseling and making sure that their information and health education is actually targeted. So it wasn't a new strategy, but it was more of leveraging and enhancing the strategy that was ongoing. And these are already within the Ministry of Health system. They're not exactly employed and hired. They're more of volunteers, but they are facilitated to do some of the work they do.
Excellent. Trained and supported. Right. Okay. It's my job as a positive women and AIDS activist to continue to fight for them to be compensated for their time.
It's important.
Yeah, of course. So I want to make sure, because obviously I can have a lovely conversation with all of you, but I want to make sure that everyone online has an opportunity to ask questions. There are some in the chat. I am trying to read and listen at the same time. So if anybody would like to just kind of raise their hand or come on screen and ask a question, please feel free to do so. I will keep an eye on all of those things. My dear colleague Jim is far better at reading the chat and also having the conversation at the same time than I am. So let's see. I think that you all can see some of these comments that are really important. A lot of appreciation for you both and Imelda as well for the work that you all are doing. It sounds like there are several initiatives. Oh gosh. Yeah. Danielle Campbell mentioned that this is a great conversation, but we've got a lot more to be talking about at CROI. And, as someone who looks at the abstracts and reviews all of that, I would say to everyone on this call, including you all, that the research is extraordinarily important, and the way we have it presented here is more people put in abstracts. So that's the little plug for continuing your good work and making sure that we can share it.
Hey, Dawn.
Yeah.
I see Yvette Raphael, that shy, retiring person
Right.
who never likes
question.
to speak up. She's got her hand up.
She does. And Yvette, I'm going to come to you in 1 second because I have Esther. I just discovered there's a Q&A section that tells you what a dynamo I am at this. And Esther put in a question. So I'm going to go to Esther's question and then call in Yvette. So Esther said, given the recommendations for the number of times pregnant women in Uganda should go for antenatal care, is it that the women should have a viral load test for all the times they attend antenatal, or should the pregnant women have the viral load test done more times than the recommended antenatal visits? Or, should this basically be aligned?
That's for me, Dawn. So when I concluded, I mentioned some of the gaps in the systems pertaining to having a viral done and the result returned to the mother. And on average, within the normal standard of care system, it takes probably 1 to 3 months. And in addition to that delay, also the recommended times when this should be done, which is a diagnosis 6 months and at 1 year, still that there's so many, there's so many missed tests that are available. So in this study, what we did, we provided baseline 6-month and 12-month point of care tests. And the goal really was to make sure that the woman understands that at this point I'm either suppressed or not suppressed. And then there also help to understand if I am suppressed and I need to maintain the suppression, this is what I need to do. If I'm not suppressed, I need to strive to get suppressed because I need it from, having an HIV-free child. And so that was the approach that we used. I guess that partially answers the question. Lee, do you want to add on that? I don't know in your settings how it is done.
No, so in our setting, it's probably done, I think, in a very similar way to Uganda. I mean, I guess the one thing that we've sort of seen through some of our work and programmatically is that, I feel like we need to probably have more of a differentiated approach to pregnant women, because I think that, some women are going to need a lot more support, a lot more, frequent viral loads. And I think that to some extent the programs are tailored, but I agree with you, Jane. I think what we see all the time is viral loads being missed, that should have been done. And obviously then missing the opportunity for intervention, figuring out what's going on, what support does this woman need, how can we help her and kind of the baby in terms of preventing HIV, but her health as well.
Yeah.
Wonderful. Thank you both. We are, as always, running a little short of time. It's inevitable. An hour goes quite quickly. Yvette, you had your hand up. If you would like to be our last word, you may. Otherwise, there's one more question in the chat that I can take.
Oh, okay, not a problem. Thank you so much, Dawn, and thanks to all the presenters. I think for me as an advocate, as a woman, and just want to echo what Danielle is saying, is that information is still limited and around women and the struggles around keeping ourselves, our babies, and our communities HIV negative. But I think most importantly, what this brings for me to mind is an advocacy point. Now that we're moving into the research for BNABs and the way forward for HIV prevention, I think it's very, very important that we don't miss this opportunity to really, really get women to participate from the beginning. We need that education. We need women to, I want us to just think outside the box and stop actually talking about how the community influence women. Let women be part of the information sessions, get to understand what HIV prevention means for them, and then they can decide and tell us who they want to be part of their sexual and reproductive health rights. I think we are missing opportunities because all of this is always about other people. And I wanted to share a little bit about the case in South Africa, but I think a lot of people already know about this case where a woman went to the clinic and there was a missed opportunity for her to get PrEP, and she wasn't given PrEP. She seroconverted, her baby was born with HIV. And unfortunately, as advocates, if we let that slide, it would mean that we are doing an injustice to that woman, because South Africa is not publicly speaking around approving PrEP for pregnant women. It's a unspoken rule. If a woman presents, if she asks, it's almost like it's a favor. Preventing HIV is a human right right now. All of these things are available, and we have to make sure that we bring the numbers down, and it has to work for women. Thank you so much.
Thank you, Yvette. We have to show up. As HIV positive women, and women at risk, we have to show up and ask for what we want. So you're 100% correct. The role of women in this, not waiting for people to ask, but to really demand that we have a role to play. I'm going to hand it over to Jim for the final closing. Thank you all for joining us. There's a lot of good stuff in the chat and some important questions. I hope we can follow up on those questions with one another over the next couple of days and keep these conversations going. Jim?
Thank you so much, Dawn, for beautiful moderating. Thank you, Lee and Jane, for joining us today. I think Imelda dropped, but we're so grateful that Imelda was able to join us. I know she was juggling a number of meetings this morning. So thank you all for squeezing us into your really busy schedules. Thank you for everyone who came either early, middle, or late to join us today. It's our last Margarita Breakfast Club of 2023, and I think it was really wonderful. I'm so grateful for all of you and all the amazing work you do. We will be following up with an email with a link to the recording, and there's a lot of links and things that were put into the chat. So we'll put those together in a document and send that out in addition to the link to the recording. So you have some of those resources that you can go back to and check out, and please learn more about our amazing speakers. They're all doing really incredible work, and connect with them. Thank you, Yvette, for closing us out on a really strong note as ever, as expected. And thank you for all of your work. I'm going to, since it is now 3 after and it is 27 minutes until the plenary starts for CROI, I am going to officially close out this webinar for today, and wish you all the best wherever you are. And if you are in Seattle, it is literally a whiteout right now. I cannot believe how much snow is coming down, kind of freaking me out. And I'm from Chicago. I'm used to snow. So for a lot of our folks who aren't familiar with snow, get ready, honey. It is really something. Maybe it'll be fun because it's new, but don't be too worried. You're gonna have to run to the convention center though. So without further ado, put on your galoshes, put on some warm hats, and we will see you all running around the convention center if you're here at the conference. Thanks again, and have a wonderful day. Bye-bye.
Bye, everyone.
Hi.